Okay, I think we should get started. Before we get going, very briefly, I also want to cordially welcome for the first time Bettina Bessler, radiologist working in Switzerland, who will be the co-host from now on and will primarily look for papers coming from Europe, although that will not be a necessary divide. I mean, we're living in a global world. And we're still working on a solution for the Australasian geographical region, which is of course much more challenging to do, but we are already speaking with Martin Ugander from Sydney, but more details will follow. So welcome to today's Journal Club, and maybe Bettina, I know you may have to leave early, but you will be hosting the November edition of the Journal Club, and maybe you just can briefly say a quick hello to everybody.
Yeah, hello to everybody. So really glad to be the co-host, and I'm already looking for papers, but I'm reading several papers and no authors are invited yet. So I'm excited to contribute and look for nice papers.
Yeah. Okay, so the papers, stay tuned. The papers for November so this time will be announced not during this Journal Club, but will be announced on the website then as soon as possible. Okay, so today's Journal Club is about function. And we know function is very important. Traditionally, function, most people think of ejection fraction, although we all know that ejection fraction is not such a great parameter. Although it has been used extensively, we know it's not very good for regional wall motion abnormalities. Its prognostic value is good, but not very good. It can be very misleading because it doesn't really reflect cardiac output. So, and that's just the systolic function. Now, when it comes to diastolic function, it's even worse. Echo has a lot of parameters for diastolic function, which just means that none of them are really good. And there are a couple of new techniques out there, such as strain analysis, flow analysis, and one recent paper, and that's the first we will discuss, was published in JACC Cardiovascular Imaging. Senior author is Martin Ugander, and first author being with us today is João Ramos. And this will be about a novel method using CMR for diastolic function. As usual, we only have 10 minutes to walk through a paper, through the PDF, and then we have some time for discussion. So keep it short, keep it to the most important messages, and leave some space for questions. Okay, João, take it from here. I will unshare my screen so you can share yours and walk us through the PDF. And welcome.
I will share mine. Can you see it?
Yes.
Yeah. First and foremost, thank you for the invitation. It's cool to be here and talk a little bit about our study. I just like to begin by saying also that this is currently in press in JACC CDI, but this current version has a lot of errors. Perhaps people who have read the article have noticed some of them, but there are some paragraphs that shouldn't be there and some changes that didn't come through. But hopefully the final version will be completely correct. The title of the study is, of course, Comprehensive Cardiovascular Magnetic Resonance Diastolic Dysfunction Grading Shows Very Good Agreement Compared with Echocardiography. I highlighted the objective, which was to develop a comprehensive comprehensive CMR approach to diastolic dysfunction grading and to evaluate its accuracy in diagnosis of diastolic dysfunction compared with echo. This being a result of there aren't so many methods to assess diastolic dysfunction in practice with CMR. There have been some attempts with myocardial tagging and some other techniques that are up and coming, but nothing very straightforward based on the main algorithm. So our goal was to, on a pilot study, on a first approach, try to test if we could replicate the way in which a basic assessment of diastolic dysfunction is done with echocardiography. I will talk about the methods a little bit later on, but in summary, we got a very good agreement with 93% agreement and kappa weighted Cohen kappa coefficient of 0.86. And I can first start with the patients that we recruited for the study. So they were from our consecutive clinical population. There was nothing really special about them. If there were patients that had an indication to perform a CMR in our camera, they had a median of 59 years old, and they were mostly ischemic patients with either ischemic heart disease or acute myocardial infarction and follow-up. A few with cardiomyopathy, including amyloidosis, a few with myocarditis, and a few with either normal findings or other indications of, for example, a normal assessment of cardiac function that the clinician thought was indicated. So this is what we wanted to do in practice. We wanted to be able to do this with CMR, so to follow this algorithm and to measure transmitral blood velocities, myocardial blood velocities, pulmonary artery pressure, or a measure of pulmonary artery pressure, and left atrial volume index. I think the central illustration is a good summary of that. And on the left side, we have the echocardiographic techniques, and to the right, we have the MRI techniques. So if we, for both transmitral blood flow velocities and myocardial tissue velocities, we, as we see, this is the standard way of measuring them in echocardiography by measuring the E, A, and E prime waves. And we replicated that using a golden angle CMR sequence that we developed in-house. And the original paper describing the technical aspects of the sequence was published in MRM by my colleague Alexander Fyrdahl. As we can see, we have quite a nice correspondence of the waves, and we measure it in exactly the same way. So we do a free breathing golden angle sequence in the mitral plane, and then we analyze it, in this case in segment, in our case, using a plugin that my colleague Alexander also developed. For pulmonary artery pressure in echocardiography, we use tricuspid jet regurgitation velocity, of course, which through the Bernoulli equation becomes a pressure gradient. And for CMR, we opted to follow the Reiter et al. Approach with the vortex duration method that we also documented in other studies. One of them, which is two of them, which are included in my doctoral thesis, actually. For left atrial volume index, it's quite straightforward in both echo and CMR, and a part of the clinical routine. There's nothing too special about that. We opted to use the biplane method with both diagnostic tests. If we now look at the results, how did CMR fare against echocardiography? Well, to start with the transmitral blood velocities, this is a set of pairs of linear regressions to the left and Blenn-Altman diagrams to the right. In the linear regression, we will always have in the horizontal axis the echocardiographic measure, and in the vertical axis, we will have the CMR measure. So if we start by the E wave, we see that we got a modest correlation between the two methods, where the straight line, the field line, is the line of regression, and the dotted line is the line of identity. We got an R-squared of 0.3, and the Blenn-Altman diagram shows a certain underestimation by CMR of the E wave, which is was quite considerable in this cohort, as you can see, with a mean bias of minus 0.16 meters per second, and a lower limit of agreement of minus 0.45 meters per second. If we move on to the A wave We see a similar tendency with a better correlation, a moderate correlation, I would say, but still a considerable underestimation by CMR. However, for the EA ratio, the correlation was very good and the bias was low, albeit we still saw a little bit of a spread that was caused mostly by these patients, something like that, a few outliers as well. But it seems that the SWIG sequence, this golden angle, high temporal resolution flow sequence, it seems that it underestimates the ENA wave. We don't exactly know why, but we suspect that it has something to do with both the position of the plane where we plan the image, and possibly because it's not an in-plane acquisition. So we plan it like any other flow sequence. And for an in-plane development, we would have to develop the sequence further. Perhaps that's a path we will take, but I'm not sure at this moment. Moving on to E prime and the E prime ratio. We've seen a moderate correlation in E prime as well, with quite a low bias with a moderate spread in the measurements. And for the E prime ratio, we also saw good agreement with some bias and some underestimation, of course, since it's dependent on the E wave, which was significantly underestimated by CMR. For the comparison between echocardiography and CMR for estimation of pulmonary artery pressure, I think this table does a better job of showing the agreement. And here in rows, we have the CMR diagnosis. And for this method, which would probably be a journal club session in of itself, but for the time being in CMR, we can observe, or in normal situations, we do not observe a vortex at all, or we observe a vortex that lies under 15% of the cardiac cycle. If we have increased PA pressure in that patient by CMR, then we'll see a vortex duration equal to or more than or greater than 15% of the cardiac cycle. For echocardiography, most people are probably familiar that either we don't see a TR jet, we see a TR jet that is under or equal to 2.8 meters per second or more than 2.8 meters per second. Then we got quite a good agreement between both methods in normal patients, or patients with a normal PA pressure, so to say. A lot of them agreed with increased PA pressure. And then there was a group of them which had diagnosed increased PA pressure by CMR, but not by echocardiography. And that was, that's an observation that we have already done in a separate study in BMC medical imaging, that CMR seems to catch some more patients with PA pressure compared to echo. Then for left atrial volume index, we've also seen a good correlation with a known overestimation of the volumes by CMR compared with echocardiography, which is well documented in the literature. And finally, we've seen, we can see here the final table with the overall agreement in the assessment of diastolic dysfunction between both methods, with echocardiography in columns and CMR in rows. We see mostly agreement, with some cases disagreeing, either because of a mismatch in pulmonary pressure or a mismatch in the EA and EA ratio. In conclusion, I think this is a promising approach. I think that going forward, it will be useful to further develop SWIG, sector-wise golden angle flow acquisition. We are thinking and working on different advancements of the method to improve ENA wave measurement, and also continuous development of the pulmonary artery pressure method in CMR, with the hopefully reduce the acquisition times. Right now, we have 6 to 12 minutes in acquisition time for PA pressure, and for the total diastolic dysfunction assessment, we have between 20 and 30 minutes total acquisition time. And that's my time, I think. So thank you, and I hope you have questions for me.
Thank you very much. First of all, congratulations. That seemed to have been quite a huge amount of work. Certainly that was worth a thesis here, because you had to account for so many, say, technical and some clinical aspects. So you said the duration for the scanning itself, it's about 12 to 15 minutes, you said?
The scanning itself for all, if we were only acquiring these measurements, I would say it lies around 20 minutes, 25 minutes. I have it exactly here in the paper somewhere.
And while you're looking, there's a question from Talal. How was E prime measured by CMR?
We measured it the same way as we measure ENA. I don't have the original paper here on hand, but it's a reference in this paper, the paper that describes the sector-wise golden angle acquisition. Yeah. And then what we get is a flow image, so a phase contrast image, where we can select the voxel with the most physiological curve that we can find. So that's we can with SWIG we can move around in the voxels and then pick the curve that we think is best fitting. From all
the user having to find the spot that best reflects the expected physiology.
Yes.
Okay.
For ENA, it's usually automatic. I mean, the program tries always to match tries always to find the curve with the maximal value. In ENA, that works quite well because the curves are quite simple. But in the myocardium, there's more noise. So usually the default pick by the algorithm is not the most optimal. So we always try, our criteria is in principle to observe an S prime, an E prime, and an A prime. And if we observe them clearly, we are content with that curve.
Okay. Maybe machine learning in the future could help with identifying these patterns. So there's one question, but please a very short answer. How do you do from Lim Woycock, how do you do a PA pressure measurement using 4D flow in MR?
Very shortly, we use a multi-2D sequence as described in the original Rater paper. We acquire the 3D volume from that multi-2D sequence, and we do a 4D flow analysis in a prototype software by Siemens. Then we identify the vortex, and we count in how many frames out of a total of 20 frames for the whole cardiac cycle, how many frames we observe, and that's the percentage of vortex duration. And then we use an empirical equation from Rater's model in the paper describing this method to convert the percentage into a pressure.
Yeah, the paper is listed in the references. So for those who are interested, can look that up, as well as the methods and the software used for this. So just quick question, how long did it take the evaluation of one case, just as a ballpark number?
Altogether. I actually said it wrong. The whole acquisition is about 7 to 12 minutes, and that is correct.
No, sorry, not the acquisition, the evaluation. So
the analysis of the images.
Processing the analysis, yeah.
I don't want to say it wrong, but 12 to 25 minutes. Yes, that is correct. I mean, in a very difficult case where all the images are difficult and probably have poor quality, then it would probably be about half an hour for everything. But in quite a straightforward case, 12, 15 minutes, I would say.
Okay, thank you very much. In the interest of time, we have to move on to Thomas Küssen. If you could just unshare your screen, João.
Yes.
So Thomas is working together with Claudia Prieto and René Bottnar on some cool stuff at the King's College in London. And one of their recent works is that on an accelerated LV function or CINE sequence. It's called CINENet. So Thomas, thank you very much for coming. The next 10 minutes are yours to go through that paper, which has been published in Scientific Reports. And it is called, you can see it here, CINENet Deep Learning Based 3D Cardiac CINE MRI Reconstruction with Multi-Coil Complex Valued 4D Spatial Temporal Convolutions. Sounds very complicated. I hope you can make this easy for us. Thank you.
I will try my best. Yeah, thanks a lot first for having me here and giving me the opportunity to present a little bit our work. So as already said, CINENet, so I will decipher a little bit all these abbreviations here in the next few minutes. The whole idea is that we initially started off by accelerating our 3D CINE acquisition by enabling by that then a single breath hold isotropic 3D CINE to assess then morphology and function. And there are different ways of going back from there. You can look at 2D and 3D free breathing cardiac CINE to counter some effects. Or you could perform single breath hold 2D real-time acquisitions, simultaneous multi-slice acquisitions. However, all the takeaway here for that is that you always are dealing with trade-offs in acquisition time, spatial or temporal resolution for a given left ventricular coverage. So what can you do and is to minimize all these errors is to perform a single breath hold 3D cardiac CINE acquisition. However, if you really want to push it, and previous work so far have only looked at either dealing with one of these compromises, is that you end up in a breath hold acquisition of around, so let's say 10 to 20 seconds, but then with an extensive anisotropic slice resolution. So in order to really push this below a breath hold of 20 seconds, the only thing what you can do is to accelerate the acquisition. However, acceleration is not that trivial, as it puts a stronger burden on the reconstruction side, meaning we have to deal with a stronger ill-posed problem. And in order to cope with that, you need to have a better spatial temporal modeling of the cardiac dynamics. And what we found, or what we have observed in our previous work, is that a fixed sparsity assumption with compressed sensing or low rank decomposition may not be able to cope with this high acceleration factors, which we need to deal with here. So that's why we looked into a deep learning based reconstruction, and it's why we came up with this multi-coil complex valued CINE network. So let me go a little bit through all these different aspects of it. Then hopefully this will get clear, and I will scroll down since this is nature style. It's the methods is down at the bottom. So the 4D CINE network, it reflects an ADMM algorithm for reconstruction. So we have an unrolled optimization network where we train in an end-to-end fashion the overall network, and it's best described if you look at here. We have our CINE acquisition, which is acquired 3D CINE isotropic resolution with our BD Casper sampling. We get the subsample bases out. From there, we perform a coil map estimation to get our coil sensitivity maps. And together with that, we perform a coil-weighted zero filling reconstruction. And this serves us then as the input to the CINE network together with the K-space and the sensitivity maps for the data consistency. And during training, we perform retrospective subsampling to have a voxel-wise correspondence with a fully sampled reference image showing the overall network. And this network consists now of these individual parts. So we first have of all these unrolled optimization in this 40 unit with data consistency blocks intermittent. And the 40 unit itself consists of this 3D spatial convolution plus 1D temporal convolutions. And furthermore, they are complex valued convolutions. So you respect the underlying complex valued nature of the data and perform complex valued convolutions as stated here in equation 5. So overall, we try to minimize now this optimization task, respecting the data consistency and performing the denoising regularizer with the CINENet network. The data consistency step includes now multi-coil information to provide a sensitivity mask, and in here we perform a one-step proximal gradient update step to enforce the data consistency. Everything is trained on 20 healthy subjects, where we, for each of them, acquired a longer extended breath hold acquisition of around 30 seconds with the 3D CINE, which has a very mild acceleration of 2.5. And we retrospectively simulated then different subsampling factors for different accelerations and for different cardiac temporal resolution, giving us the different 4D volumes, which are then sent into the network to train. And everything is then trained on 2 GPUs, since this is quite computationally intensive. However, then inference can be done on CPU within a few seconds. For the acquisition, we looked at a 1.9 millimeter isotropic target resolution in 20 healthy subjects and in 15 patients. And we kept the number of cardiac phases fixed to 16, meaning we have temporal resolution in the range of 38 to 56 milliseconds. And in terms of acquisition time, we looked at different acceleration factors, ending up, so 9, 11, and 15 for the healthy subjects, ending up in a scan time or single breath hold of 12, 10, and 7 seconds. And for the patients, we were a little bit more lenient in order of the acceleration factor to be sure to get good images out with a 12 times acceleration, so ending up with a 10-second breath hold here. And if we look now at some results, and sorry, I need to scroll up for that, is for here in the figure 1, you see this reference acquisition, so the reference data which we use for training of the 3D CINE in comparison to a conventionally acquired 2D CINE, which is done under multiple breath holds in an overall scan time of 260 seconds. On the right-hand side, you see then these prospectively undersampled cases with a 9 times, 11 times, and 15 times acceleration with the respective scan times below. You see the zero-filled input to the network, which gets then reconstructed to this CINENet output. So this is then the CINENet reconstruction. And for comparison, we looked at compressed sensing reconstruction with a fixed L1 wavelet along the spatial and a TV denoising along the temporal domain. And we see that we can can reduce these subsampling artifacts quite nicely with the proposed CINENet. And this also holds quite consistent over the different acceleration factors. If we look here, for example, in the highly accelerated case, it tends starting to fail for the compressed sensing one, whereas for the CINENet, we get still a nice reconstruction out. Overall, the network has 2.1 million trainable parameters, and we use the convolutional kernel sizes in similar to our previous method, the multi-beam PROS reconstruction, where we try to share information along local and non-local scales and along the cardiac dimension, temporal dimension. So therefore, we looked at a spatial receptive field of view coverage of around 33%. So you can think about it like doing a patching or looking at local neighborhoods within the spatial domain. However, in the temporal domain, we used 100% of the data, allowing a sharing over the overall time. And the same also holds true if we look at a second subject, or if we look also into the patients. So here you see patient 1 and 2 for different cardiac phases, systolic and diastolic phase, with a 10-second acquisition. We see zero field, very blurred and aliased content. Here we have especially aliasing of the subcutaneous chest fat in here, which gets nicely suppressed then by our proposed CINENet reconstruction. We also can provide whole left ventricle coverage with isotropic resolution. This also allows then you to perform some reformatting in arbitrary orientations. For that, you can check in the paper the supplementary materials where we show some reformats for that. If we look now at some contrast comparison, we see that the 3D CINE, as already showed in our previous work, is always impaired by contrast differences to the 2D CINE because we have this selective excitation. So the excitation in comparison to a slice selective excitation of the 2D CINE, which can benefit from unsaturated blood flow into the left atrium. And here we see that, however, this 3D CINE with the CINENet reconstruction is not statistically significant impaired by this contrast differences, measuring contrast between myocardium and left-right ventricular blood pool. And however, only in the highly accelerated cases we found that this is statistically significantly impaired, whereas the compressed sensing one was always impaired for all the cases here. If we look at some quantitative,
Thomas, we have to keep it short. We're already
yeah,
over time.
this will be my last. If we look at the left ventricular function assessment, we see very good agreement between the 3D CINE and 2D CINE. Very minimal bias and very tight confidence intervals for both the healthy subject shown here and as well as the patients. And that's it for my presentation. If you have questions.
Thank you very much. So if I may summarize, so this is a new sequence that with an acquisition of, you use mostly something between 10 and 20 seconds, provides images that can be reconstructed in a way that the image quality is preserved. And certainly that's a valid alternative in an age where we have to be very conscious of cost and time efficiency and so forth. So I think this is quite exciting. Just a quick question, and I also saw that René is also on the call. So René, feel free to chime in as a senior author here. So or together with Claudia, team leads here. So is there a free breathing version for that, or will you continue to go for breath holds?
So the aim is so we are looking at free breathing acquisition. We have just recently published our work on free breathing acquisition and reconstruction in a conventional fashion. So now we are looking that this can be extended also with a deep learning based reconstruction for free breathing acquisitions.
Yeah.
So
and any plans to integrate that into kind of a multi-parametric strategy with tissue characterization? So just comparing this to approaches like multitasking and free running framework and the others. I know, René, that you're also in parallel working on other stuff. So just a brief comment on that.
Oh, there's certainly plans also to look into multiparametric imaging and in using, let's say, deep learning approaches, but we don't have any solutions yet.
Okay.
But certainly that's certainly something for the future to look into.
But congratulations, the great work. Quick question from Attila Todd from Budapest. What's the memory requirement to perform the training and the recon currently? How big is your machine?
The memory requirement is quite high, so it's trained on 2 GPUs, in total 48 GB, depending on the batch size you're using.
Wow.
For this, the stated values here is 48 GBs.
That's probably almost as much as computer networks for hospitals used to have when I started working. So,
yeah.
Okay, thank you very much. Can you unshare your screen? So I think Bettina may have already left. As I said, the contents for the next journal club will be announced as soon as possible. I just wanted to point to a couple of papers that I found interesting, just to briefly point you to them. This is a nice paper published in JCMR on Leighton Hansen in trained endurance athletes that also refers to another paper where there were interesting findings in COVID, in athletes with COVID. So, so if you just send us an email, but we will post them. And then I also want to point to a kind of a landmark paper. So the Gadabutor enhanced CMR for detection of coronary artery disease. This is basically the GADACAT studies that have been published here with Andrew Arai, the first author published in JACC. Where this was the study, or those were the 2 studies that eventually led to the approval of gadolinium for perfusion imaging by the FDA. And so these papers are interesting and everybody should have a look at that. With that said, I want to cordially thank again the authors, João and Thomas, and also René, and everybody else for joining in. And I'm looking forward to next time. Don't forget, there will be a JCMR Journal Club. I think it's next week. I'm sorry I don't have the paper now present that will be published, but join in next Wednesday at 11 o'clock. But